Professor David Taggart from the UK. He will be introduced by Dr. Feng.
It gives me great pleasure and honor to introduce this year's Israel Society of Cardiothoracic Surgery's guest lecturer, Professor David Taggart. Professor Taggart has distinguished himself early on in his medical career. He graduated with honors from Glasgow University, continued his cardiothoracic training at some of the most leading medical centers in Great Britain, joined the John Radcliffe Hospital in Oxford as a consultant in 1995, and finally received his professorship in 2004. He has authored over 150 papers that have been published in peer-review medical journals and serves regularly as an editor and reviewer in some of these journals. Professor Taggart has devoted most of his professional career researching the topic of surgical revascularization for ischemic heart disease. In this pursuit, he has taken on investigating and even critiquing some of the seminal papers that have been published comparing the two main strategies of interventional treatment, CABG and coronary stenting. His conclusions have been most interesting, if not provocative. He has challenged the validity of some of the major papers' conclusions, questioning their methodology and statistics, and actually showing that CABG really is the superior choice of myocardial revascularization for ischemic heart disease. This has come, I might add, at a price, making him sometimes persona non grata at some of the major cardiology meetings, causing some friction and tension. But may I add, David, that you're in a friendly audience here, and no harm will come to you, I guarantee that. We are a friendly audience. Professor Taggart's greatest achievement, I believe, is in his understanding that the future of the treatment of ischemic heart disease is not a silo-based approach, cardiologists and cardiac surgeons separately, but rather a joint, comprehensive team effort. David has served as one of the committee members that rewrote the ESC's guidelines on myocardial revascularization that was published in late 2010, where he introduced the concept of the heart team, which is now being applied worldwide. He most recently headed the working group on CT surgery for the ESC. It is through such renewed and an original approach that together cardiologists and cardiac surgeons must focus on the future, delivering the optimal and best treatment for our patients suffering from ischemic heart disease. David, it is a pleasure again to host you here in Israel, and we look forward to hearing your interesting topic, CABG and PCI 2010, Facts and Politics. Bruchim habayim.
Thank you very much. Thank you. Good morning, ladies and gentlemen. Let me first thank Danny for that extremely kind and generous introduction. And let me also thank the Israeli Heart Society and the Society of Cardiothoracic Surgery of Israel for the great honor and privilege for being here today. This is my fourth visit to Tel Aviv. It's a great, beautiful city in a wonderful country, so I'm really delighted to be here. Today I am going to talk about CABG versus PCI, current practice in politics in 2014. I do have some potential conflicts of interest, clinically as a cardiac surgeon. Commercially, I do act as an advisor to several companies, but none of them are relevant to today's presentations. I was one of the 25 ESC EACTS guideline writers, and I'm the chairman of the surgical committee of the EXCEL trial. The first thing to point out is that the results of contemporary coronary artery bypass grafting are excellent. This is a one-year outcome of a randomized trial of 3,000 patients to single or bilateral internal mammary artery grafts, where the primary outcome is in fact 10-year survival. But the point to note is the 30-day mortality was 1.2%, the one-year incidence of stroke, MI, and repeat revascularization all under 2%, and an interim 5-year analysis of this trial will be published later this year. But I would emphasise again, the current results of contemporary bypass grafting are excellent, but only fewer than 5% of patients in the United States and fewer than 10% in Europe actually receive bilateral internal mammary artery grafts. The second thing to bear in mind is that there is good evidence that there is no benefit of the routine implantation of stents in patients with stable coronary artery disease over optimal medical therapy. This was shown in this meta-analysis of 8 trials with 8,000 patients followed up for 4 years, where the authors concluded initial stent implantation for stable coronary artery disease shows no evidence of benefit compared with initial medical therapy for prevention of death, non-fatal MI, unplanned revascularization or angina. Now, when we look at the evidence base for any intervention, and in this case specifically CABG versus PCI, there are 2 forms of evidence we can consider. The randomized controlled trial, which is the gold standard because it eliminates bias, but many randomized trials have a number of potential weaknesses. They often include only a small number of patients. They often enroll only a small percentage of the eligible population. They therefore often end up with atypical patient populations. This is compounded by short durations of follow-up, large numbers of crossovers. They're expensive to run, and this is true for 19 of the 20 trials of PCI versus CABG. The second form of evidence we can consider are propensity match registries. These often contain tens of thousands of patients. They actually represent what we do in everyday routine clinical practice, and they're relatively cheap to run. But of course, the major limitation or potential weakness is the possibility of confounding by biases that we may know about and biases that we do not know about. So when we look at any randomized trials, 2 questions we must always critically ask is what percentage of the eligible population were included and what was the duration of follow-up. Now, if you look first at the relevance of the total eligible population included in trials, in 2006 I was privileged to give the Ferguson Lecture to the STS in the United States, and at that time I analysed 15 trials of PCI versus CABG. And the point I made was that although these trials in total enrolled about 9,000 patients, they only actually included 5% of the total potentially eligible population. And I don't know if you can see the red box at the bottom, but what it shows is that the patients in the trials, none had left main disease, only 1/3 actually had 3-vessel disease, and only 40% had proximal LAD disease. And these trial patients were therefore very different to what we were doing in practice, because in our CABG practice at that time, 20% of patients had left main, over 90% had 3-vessel disease, and over 90% had proximal LAD disease. So the trial patients enrolled into all of these trials of PCI versus CABG were very different from those in routine clinical practice, yet the results of these trials were then generalised to the whole population with ischemic heart disease. And the second point I made was the relevance of the duration of follow-up of patients. And this is absolutely crucial. I've shown here 4 different registries, 3 of them published in the New England Journal of Medicine. The New York registry of 60,000 patients comparing CABG with bare metal stents, and all the other registries here are CABG versus drug-eluting stents. And you can see 2 things from these registries. There is always a survival advantage of CABG by around 5 to 7 percentage points by the time you get to 5 years. But if you follow these survival curves, you can see that they continue to diverge out past 8 years, suggesting that at even 5 years, the true benefit of CABG may be underestimated. I could today show you 13 propensity match registries with over 430,000 patients, all showing this consistent survival benefit of CABG, and this indeed was an important warning for the Synthetix trial. Now, the Synthetix trial, the 1-year outcomes were published in the New England Journal in 2009, and the Synthetix trial is a landmark trial. It is unquestionably the most important trial ever performed of PCI versus CABG, because it addressed the 2 major limitations of all the previous trials. The first is that in relative terms it was an all-comer trial. versus the highly select patient populations of the previous trials. And secondly, it actually looked at 5-year outcomes of death in MACE, published in The Lancet in 2013. But another important facet of Synthetix was it had a nested parallel registry to look at what happened to all the patients who were deemed ineligible for randomization. And the vast majority of these patients were ineligible for randomization because they had coronary disease of such complexity it was deemed untreatable by percutaneous intervention. So before we even look at the randomized component of Synthetix, note that 1/3 of all patients had gone straight to bypass grafting. Now, if you look at the 5-year results of Synthetix for 3-vessel disease, we can see that in terms of CABG, there was a marked clinical and statistically important reduction in death, cardiac death, myocardial infarction, and the need for repeat revascularization, and there was no increase at 5 years in the incidence of stroke. And we shouldn't be surprised by the 5-year results of Synthetix because they are entirely consistent with what all those registries have been showing us for the last decade. If we divide these patients according to the complexity of coronary disease into low, intermediate and high categories, we can see that it's only in patients with Synthetix scores below 23 that there is no survival advantage for CABG, although there is still a marked reduction in the need for repeat revascularization. But in the intermediate group, there is a 7% survival advantage for CABG. In the higher tertile group, a 9% survival advantage for CABG. And this is accompanied by a marked reduction in myocardial infarction and the need for repeat revascularization. And finally, I would emphasize again that if you look at the survival curves at 5 years for Synthetix in patients with 3-vessel disease, they continue to diverge, suggesting that the true benefit of CABG may still be underestimated. Now, this is an important meta-analysis of the randomized clinical trials of arterial grafting in the stenting era, published in JAMA last year, looking at 6,054 patients, including those from Synthetix, where the hazard ratio for CABG versus PCI was 0.73, highly clinically and statistically important. And if you look also at the CABG hazard ratio for myocardial infarction, repeat revascularization, these were both very significantly reduced with bypass grafting, and there was no overall statistical increase in the risk of stroke with a hazard ratio of 1.36. If we look at patients with diabetes, the initial clue to what would happen in these patients was the Barry trial. The 10-year outcomes were published in JACC in 2007, showing a 12% survival advantage for CABG over PTCA. In 2009, Hilatke looked at 1,233 diabetic patients treated with either CABG or PCI and showed that the hazard ratio for CABG was 0.7 and accounted for an absolute 10% difference in survival at 8 years. And if we then look at the most definitive randomized trial, the Freedom trial, this randomized almost 1,900 patients at 5 years of follow-up, an absolute difference in MACE of 8 percentage points, but crucially an absolute survival advantage for CABG of 5.4 percentage points. And if we look at the ASSERT registry, the most powerful registry, looking at 190,000 patients, propensity matched for either CABG or PCI, we can see that when you divide this data according to age, above or below 75, gender, BMI, race, the presence or absence of diabetes, lung dysfunction, peripheral vascular disease, previous myocardial infarction, renal dysfunction of varying severities, overall ejection fraction or impaired ejection fraction, overall risk, and severity of coronary disease according to 5 quintiles of severity, every single way you look at this data, there is a strong survival advantage for bypass grafting. So we might now ask the question, why does CABG have such a survival benefit over PCI? And there are 3 reasons, but they are predicated on the fact that anatomically, atheroma is mainly located in the proximal coronary arteries. So this has 2 important implications for bypass grafting, because by placing the bypass graft to the mid-coronary vessel, this has 2 effects. It not only makes the complexity of the culprit lesion irrelevant, but over the longer term, it offers prophylaxis against future culprit lesions. In contrast, PCI only treats suitable localized proximal culprit lesions but has no prophylactic benefit against new disease. And the second important pathophysiological factor was shown by Professor Luscher almost 3 decades ago in the New England Journal of Medicine, and that was the benefit of an internal mammary artery to the LAD. Because the increased nitric oxide production of the internal mammary artery not only ensures the patency of that conduit, but it prevents and reduces the risk of further development of disease in the native coronary circulation. And in contrast, Dr. Luscher also showed that by placing a drug-eluting stent in the proximal LAD, it impairs re-endothelialization, it creates a prothrombotic environment, and it impairs endothelial function downstream of the stent. The third reason is PCI means incomplete revascularization for many patients, and Hannon showed in a series of almost 22,000 patients undergoing PCI that 70% had incomplete revascularization, and that the subsequent mortality of these patients correlated directly with the degree of incompleteness of revascularization. So for these reasons, we can say PCI is unlikely to ever match the results of CABG for the vast majority of patients with multi-vessel disease, and as we will see also for most patients with left main disease. It didn't with balloon angioplasty, it didn't with bare metal stents, and it has not done so with drug-eluting stents. And this point was recently emphasized in this meta-analysis by Bangalore, published in Circulation in 2012, looking at the outcome of patients comparing bare metal and drug-eluting stents. And what they showed conclusively was that while drug-eluting stents do reduce angiographic restenosis, they do not reduce death or myocardial infarction in comparison to bare metal stents. And if you think back to the previous slide I showed you, you can understand the reasons for this. I would now like to turn to left main, because back in 2008, I co-authored this paper with several colleagues from Europe and United States, when at that time we looked at all the evidence in the literature comparing CABG and PCI in patients with left main stem stenosis, and we concluded that CABG should remain the preferred revascularization treatment in good surgical candidates with unprotected left main. And we based that on the pathophysiological observation that up to 90% of left main lesions are distal or bifurcation lesions, and we know that these are at high risk of restenosis. Furthermore, up to 90% of patients with left main have multi-vessel coronary disease, where CABG already offers a survival benefit independent of the presence of left main stenosis. So that was the thinking in 2008. Then in 2011, Dr. Park and colleagues from the Asan Medical Center in Korea published the pre-combat trial in the New England Journal, where they randomized 600 patients with left main with relatively low Synthetix scores and Euro scores to either PCI or CABG, where the primary endpoint was death, CVA, MI, and repeat revascularization at 2 years. And what they showed was, on the composite endpoint, there was a 1/3 reduction in this in favour of CABG at 2 years. However, if you removed from the primary endpoint revascularization and looked at death, stroke, and MI, there was absolutely no difference between CABG and PCI. If we now look at the 5-year results of Synthetix for left main, published in Circulation last month, we can see that overall there was no significant difference in MACE, death, stroke, or MI, or all-cause death. There was a significant increase in the risk of stroke with CABG, being 4.3 versus 1.5% for PCI. And if we look at these all-cause death and stroke and repeat revascularization, these were very different from what we saw in the cohort with 3-vessel disease, where CABG offered a strong survival benefit and no increase in the risk of stroke. If you look at these left main patients according to the complexity of disease as defined by Synthetix scores above and below 32, we can see that it's only in the patients with the highest risk tercile, those with scores 33 and above, is there a significant benefit to bypass grafting in left main disease. And the working hypothesis may therefore be that, unlike 3-vessel disease, left main without additional proximal coronary artery disease may result in excessive competitive flow for bypass grafts. This will be resolved by two trials: the NOBLE trial, which is planning to recruit 1,200 patients with left main, and the EXCEL trial, which was started in September 2010. Now, EXCEL is only recruiting patients with Syntax scores below 33. It has two components: a 1,000-patient registry, which has now been completed, and it was planned to enrol 2,600 patients in the randomised component. But Abbott have stopped enrolment into the trial in March of this year for financial reasons. They've spent almost $50 million to date and reckon it would cost another $40 million to complete this trial, but there are still 1,906 patients who have been randomised. Now, possibly the best meta-analysis of drug-eluting stents versus CABG in left main coronary artery stenosis is this paper by Athappan and colleagues. They looked at 24 studies, including 3 randomised trials, but involving 14,000 patients with left main treated by PCI or CABG and followed out to 5 years. And what they showed was that from year 1 to year 5, there was absolutely no difference in mortality between CABG and PCI. They showed that with regards to myocardial infarction, for the first 3 years, there was a significant increase in this with PCI. And they showed that for target vessel revascularization, there was a significant increase in this with PCI for years 1 through to 5. If, however, we look at stroke, this analysis also showed that for CABG, there is a significant increase in the risk of stroke every year in left main stem stenosis, and that overall for MACE, there was no difference between the groups for the first 4 years, but by 5 years, there was a significant increase in MACE for CABG. In a further analysis of this data, according to the Syntax terciles as being high, intermediate, and low, this again confirmed that CABG was only superior to PCI in those in the highest tercile with respect to death, myocardial infarction, MACE, and target vessel revascularization, but not in the intermediate and the lower tercile groups. So now I'd like to say something about the actual practice of PCI versus CABG. And this first slide shows the ratio between elective PCI to CABG per 100,000 of population in 24 OECD countries. So these are countries with broadly similar economic situations. And you can see the numbers of CABGs are in red per 100,000, PCI is in blue per 100,000, and then you can see the ratio between PCI and CABG. And the average for the OECD is 3.3 to 1. But if you look at the bottom of the graph, if you look at the United States, Italy, France, Spain, here the ratio of PCI to CABG goes from 5 up until almost 9 to 1. And I believe, although Israel is not in this graph, I believe the ratio in Israel is also in approximately 9 to 1. But the question becomes, why do you have a 4-fold difference in similar European states with similar populations and similar economies in the ratio of PCI to CABG? But we see this phenomenon not just amongst different countries, we see it within the same country. And this is a paper from the Canadian Medical Association Journal. It looked at the rates of PCI to CABG in the 17 cardiac centres in one province of Canada, Ontario. The authors made the point that only 4% of patients were discussed by a multidisciplinary team. But what they showed was that the ratio of PCI to CABG in this same population varied from just over 1 to 1 in Hospital A up to over 6 to 1 in Hospital Q. So a 5-fold difference in the ratio of PCI to CABG depending on which hospital you found yourself in. And these authors interpreted the physician performing the diagnostic catheter and the treating hospital were strong independent predictors of the mode of revascularization. Opportunities exist to improve transparency and consistency around the decision-making process for coronary revascularization, most notably among patients with non-emergent multivessel disease. And what is happening here is explained in this paper by Hannon, published in Circulation in 2010, when he looked at the outcome of 16,000 cath lab patients in New York between 2005 to 7, where the treatment decision was made by the cath lab cardiologist alone in almost 2/3 of cases. And what it showed was that even if you had a Class 1 ACC-AHA recommendation for CABG, only half the patients got CABG, but 1/3 were still submitted to PCI in direct contravention of what the guidelines said. On the other hand, if you had a Class 1 indication for PCI, 94% of patients got PCI. And where there was true equipoise between the interventions, still over 90% of patients received PCI. And the authors pointed out that 92% of the PCI procedures had been performed on an ad hoc basis, so performed immediately after the angiogram, but meaning in reality the patient was given no time to discuss any other options, and undermining the concept of genuine informed consent. And again, perhaps not surprisingly, the chance of PCI increased in the hospitals with PCI facilities. And what this slide emphasises clearly is that when you do not have heart teams acting on guidelines, you significantly increase the rate of the wrong intervention. Now, one of my colleagues published this paper looking at 10 studies of 1,500 patients, 1,000 PCI, 440 patients undergoing CABG, and these patients underwent questioning by a questionnaire after the intervention. Now, CABG is in blue, PCI is in pink, and what you can see is that 80% of CABG patients thought that the operation was designed to improve angina, but only 50% of patients undergoing PCI thought that that was why they were having PCI. But what is absolutely striking is over 70% of the patients undergoing PCI reported that the point of the PCI was to extend their life expectancy and to prevent further myocardial infarction. Two things that we know PCI certainly does not do. And in terms of offering patients alternative therapy, although these patients all had multi-vessel disease, 2/3 of the CABG patients were offered alternative therapies, but only 15% of patients undergoing PCI with multi-vessel disease were even given the option of a discussion of coronary bypass grafting. And again, this emphasises the need for guidelines, and it emphasises the need for recommendations for interventions to be made by a heart team rather than an individual practitioner. Now, in my penultimate slide, if you look at what do the 2010, that's the European guidelines, and the 2011 North American guidelines, what do they actually recommend? I've summarised them according to CABG and PCI, and I've then subdivided them into the European and North American recommendations. Both in Europe and North America, there is now a Class 1C recommendation for the heart team for patients with left main or complex coronary disease. If, however, we look at the 9 patterns of coronary disease, so that's 1, 2, or 3 vessel disease, and then 4 categories of left main. If we look at CABG, we can see that for ESC and ACC, most of the indications are Class 1, meaning this is what the patient should have. If we look in contrast at PCI, without going through the 9 categories, you can see that most recommendations for PCI are either Class 2 or Class 3. Class 2 meaning you should be cautious about it, and Class 3 meaning you shouldn't do it. And the key point to take away from this slide today is that as we practice in contemporary clinical practice, almost 80% of patients with 3-vessel coronary disease have Synthetix scores above 22, they have a Class 1 indication for CABG and a Class 3 indication for PCI, and the same argument applies to almost 2/3 of all patients with left main disease. And again, I would emphasise there is broad agreement between the European and the North American guidelines. So to summarise and conclude, there is consistent evidence that PCI has no clinical benefit over optimal medical therapy, and that drug-eluting stents do not improve clinical outcomes over bare metal stents. Almost 80% of patients with 3-vessel disease, that is those with Synthetix scores over 22, have a strong survival benefit with CABG. It's apparent by 3 to 5 years, and it continues to increase past 5 years. There is consistent evidence from over 13 propensity match registries with 430,000 patients of this strong survival benefit of CABG in comparison to PCI. For left main disease, almost 2/3 of patients have Synthetix scores above 32. There is a survival benefit with CABG by 5 years, but the cost of this is a higher instance of the risk of stroke. However, for patients with left main with Synthetix scores below 32, there is increasing evidence that PCI may produce, at the very least, equivalent results to CABG with regards to mortality, if indeed not superior results, and this may be because bypass grafts are disadvantaged when you do not have additional proximal coronary disease by too much competitive flow. In these patients, there is also a lower incidence of stroke with left main, but the definitive answer in this category of patients will be given by the Excel and the Noble trials. If we're making comparisons of PCI versus CABG, there should be a minimum duration of 5 years of follow-up to really determine the relative efficacies of both these interventions. There is consistent unwarranted variation in the ratios of PCI to CABG, both between countries and within individual countries. There is strong evidence that the absence of multidisciplinary teams or heart teams using guidelines means that most elective PCI patients misunderstand its rationale, and this results in a large number of inappropriate or wrong PCI interventions. I would argue that guidelines are transparent. They not only protect the best interests of patients against wrong interventions, but I think they act in the best interests of doctors to ensure that patients receive the best interventions, and I feel that guidelines should be mandatory. Indeed, I would finally say that I think professional bodies should persuade statutory bodies and payers that only interventions agreed by a multidisciplinary team based on guidelines or documented as to why guidelines have not been followed should be reimbursed. On that point, I'm going to conclude my talk. I would like to thank the organisers again for the great privilege of being here today, and I'd like to finally thank you, the audience, for your attention. Thank you.
Thank you very much, David. Well, I have one comment and one question. Here in Israel, we're approaching 40% of utilizing bilateral memory. There are centers which are using it in about 90% of the cases. So in the light of all the facts that you mentioned, how do you explain the very low percentage of using bilateral memory in the States and in Europe?
I think it's very difficult to explain, and I have often been accused of criticising cardiology practice, but when I go to a cardiac surgery meeting, I make this point repeatedly. I think there was good evidence more than a decade ago of the benefit. I haven't shown the evidence today because of lack of time, but there's been good evidence for well over a decade of a strong survival benefit with 2 internal mammary arteries, yet the cardiac surgical community has been very slow to pick this up. And I'm not clear why that is, but it is certainly a legitimate criticism of cardiac surgery practice.
Okay, Professor Lucia.